Hello, I'm Dr. Valerie McLaughlin, Director of the Pulmonary Hypertension Program at the University of Michigan. I'm joined by my colleagues Dr. Richard Chanik and Dr. Ioana Preston to talk about some of the key takeaway messages that were held at the 6th World Symposium on Pulmonary Hypertension in early 2018. Rich, Ioana, you were both on the task force that addressed risk stratification and medical therapy, part of that very lively discussion. Ioana, do you want to tell me a little bit about your approach to initial risk stratification of a patient with pulmonary arterial hypertension?
Well, nowadays, in 2019, we've learned that we have to take into consideration several parameters that are important in predicting the outcome of our patients, both at diagnosis and as follow-up. And we have now compelling data that tells us how to put these parameters into perspective and how to use them by calculating several risk score systems to understand how severe the patient is and how aggressive we should be with therapy.
That's great. So there are many. Tell me what you use in your everyday practice. How do you approach that newly diagnosed patient?
We have three more recent scores that one could use in clinical practice. The REVEAL score, which is a US-based score, and the 2.0 version is more simplified version of the initial one. Then the French score and the Swedish and German score classifications. They all have important parameters. In clinical practice, we sometimes use the French score because it is the easiest to calculate, although we understand that the REVEAL score has probably the best prediction in large cohorts. But they all take into account functional class, NT-proBNP or BNP, 6-minute walk distance, and some of them several hemodynamic parameters.
And so that initial risk stratification to make your initial treatment decision is just step one. Something that is really emphasized in the algorithm from the World Symposium is that structured reassessment of patients. Rich, why don't you tell us how you approach that?
Yeah, I think that's a critical point, Val, that, and the data supports it as well, that, almost regardless of where somebody starts out, if you can get a patient to a low risk status, that's associated with an improved outcome. And so that concept is really critical and really forces a clinician to frequently reassess patients to get them to that low risk status. As Ioana alluded to, there's different ways to assess and reassess. There are non-invasive parameters, functional class, 6-minute walk distance, BNP levels. There's more invasive, like right heart catheterization. And as we emphasized in the symposium and our task force, some method of stratifying and reassessing, almost regardless of which one you use, is important. We didn't advocate one over the other. We said risk assessment, reassessment, and then adjusting therapy to get patients to low risk. And by that, we mean starting with an aggressive combination therapy approach for the vast majority of patients and then adding on from there.
Until they get to low risk status.
Correct.
And then once they're in low risk status, it's also important to remember that we have to keep reassessing them because we want to keep them in low risk status.
Exactly.
Great.
So we learned not to stabilize the patients, but bring them to the low risk status, which is very important.
Right. I think the main difference, what you're trying to point out, is we're not just looking back, are they stable compared to last time? We're looking ahead. Are they in a status today that predicts that they are not likely to have bad outcomes or events coming up?
Okay.
Right. So. Well, Rich, Ioana, thank you for joining me. This was a great discussion. Thank you for joining us to talk about the risk assessment and treatment algorithm from the 6th World Symposium on Pulmonary Arterial Hypertension.